So we're going to talk about small cell lung cancer. A lot of this data is rehash of prior data, some updates. So nothing too exciting. We're just going to put in some salient things to figure out if we can make some head or tail of this. Next. All right, the first one is the IM Power 133 data. All of you have seen this study. This is exploring the use of Tecentriq or atezolizumab with chemotherapy in extensive stage small cell lung cancer. This is an updated overall survival and also a small real world comparison study. Next. So this is the treatment schema. Patients with good performance status, untreated extensive stage, no previous treatments, were randomized to chemotherapy with carboplatin and etoposide, given for 4 cycles, not 6, as compared to 4 cycles plus Tecentriq, and maintenance Tecentriq versus placebo, until there was progression of disease or loss of clinical benefit. The median overall survival update is at about 23 months, and at 302 days occurred initially. Next. These are the patient characteristics, nothing great out here. Median age of about 65, 2/3 of them were male, small number of Asian population of about 15%, current smokers about 1/3, former smokers about 60%, a small number of patients with brain mets about 8 to 10%, liver mets in about 38%. Next. This is the updated overall survival data. So the good news is the curves still remain divergent from each other. At 12 months, we have 51% versus 39% overall survival. And the median overall survival, one of the few phase 3 studies in extensive stage small cell lung cancer to cross the landmark 1-year point, which is been a big improvement in small cell lung cancer, I should say. And what we're seeing here is that at 18 months, the survival seems to be still preserved, 34% versus 21%. And at 2 years, we're still seeing some splitting of the curve. Hazard ratio is still pretty good at 0.76, translating to a 24% improvement in overall survival with the use of immunotherapy in addition to chemotherapy. Next. Again, this is updated overall survival subset analysis. The one thing that did here was to look at PD-L1 and TMB to see if that will predict who will have a response to immunotherapy in addition to chemotherapy. And clearly, we didn't see any major difference between the two groups. So overall, all the groups seem to benefit with some crossing over when the numbers are very small. Obviously, for instance, brain mets is only 35 patients. There's a crossing of the graph there. But again, everything is to the left of the forest plot line. Next. This is the updated subgroup analysis, again, looking at intention to treat in patients where there was biomarker available population. So that accounted for roughly about 40% of the patients had some data on PD-L1 and also on TMB. And the news is that TMB and PD-L1 does not seem to correlate with improvement in either PFS or overall survival. Next. This is the real-world retrospective comparison using the US Oncology Network data. On the left, you'll see the IM Power 133. On the right side is the real-world study. Median age is very similar. Caucasian population of about 70 to 80%. The real-world study included about 24% of patients with PS2, which is probably what you see in your practice. And this was not there in the clinical trial. And then the brain metastasis was higher in the real-world study of 22% as compared to 8% on the trial. Next. This is the comparison of the data. Median follow-up of 13 months in IM Power. The real-world study has only about a 5.4 months, so fairly limited data. Median duration of treatment seems to be the same on the trial as is in the real world of about 4.7 months. Percentage of patients still on treatment at 6 months seems to be very similar, 31 versus 35. Median PFS seems to be similar, 5.2 versus 6.9 months. And people not progressing on to second line seems very similar. So I think this gives us a lot more evidence in
If Sujit, if you can hear, you're frozen there.
Yeah, okay, I'm frozen. Let's see.
No, you're good now. You're good.
Now we're good. Okay. So what we're seeing is that atezo plus chemo continues to provide benefit and should be considered practice changing and something we can obviously implement in our clinics. Next. All right, next. The next study I'm going to present again an update is a Caspian study, very similar to the atezo study. This is asking the question, does durvalumab or Imfinzi in combination with chemotherapy provide benefit in patients with extensive stage small cell lung cancer? Next. So this is the study schema. Again, patients with good performance status, PS0 or 1, asymptomatic or treated and stable brain metastasis, life expectancy of more than 3 months, 3-arm study, durvalumab plus chemotherapy for 4 cycles, durvalumab plus tremi plus chemotherapy for 4 cycles, and chemotherapy given up to 6 cycles. So some of them received 4, some of them received 6. And all patients received maintenance durvalumab after completion till progression of disease, and PCI was optional. Just a quick segue into the PCI in extensive stage small cell lung cancer. So it became kind of in vogue when the trials came out suggesting reduction of brain recurrence and maybe a modest improvement in survival benefit of about 1.5 months initially. Then there was a Japanese trial, a Japanese cooperative oncology group trial, which looked at this question.
Sujit, I think you froze again.
Yeah, he's frozen.
Dr. Kalmadi, perhaps turn your camera off and just leave the audio on. Thank you.
Can you hear me now?
Yes.
Okay, sorry. So the Japanese oncology group study showed that there was no improvement in overall survival by adding PCI. And in fact, it crossed the futility boundary, and you could argue it could have been detrimental in a small subset. And so since then, I've lent some thought to this, and I do offer surveillance with MRI instead of PCI in my patients with extensive stage. What's your practice, Eric and Tarek? Maybe Eric, you can comment on PCI in extensive stage small cell. Do you do that, or do you offer it?
No, I'm like you, Sujit. I've gone away from PCI in extensive stage. Based
Eric,
on exactly what you said, the Japanese as well as a British study as well.
Yes. Eric,
Yeah,
what's your thoughts?
I agree. I think the toxicities you get from PCI is not beneficial, especially with potentially 2 trials that show very limited benefit or no benefit at all. So I agree with you. I actually do active surveillance, every 3 months or so, take a picture and then decide from then. But I do not offer it.
Okay. Next. Next. Oh, sorry. Okay. So this is the Caspian 3-year overall survival data. Again, this, oh, sorry. Can you go back to the previous one? Joel, can you guys hear me?
Yes.
Okay,
Yes, yeah, you're good. And if you afraid of freezing again, Nikki said, if you just want to turn your camera off, you can. Just keep the
Okay.
sound on.
Maybe I'll switch it off. All right. So this is the 3-year updated overall survival data, looking at chemotherapy versus chemoimmunotherapy. Again, median overall survival of more than 12 months. 3-year overall survival that is divergent. So again, it gives us definite confidence that immunotherapy does add to chemotherapy in this setting. Next. So again, looking at subset analysis, everything is to the left of the one line in the forest plot. So no subsets where there was some extra benefit or lack of benefit that we can think of. Next. Next slide. Sorry, am I frozen again?
You are not.
Can we get the next slide? Oh, there it is. Okay, thanks. So this is looking at the ongoing treatment exposure. Very similar, the duration, total duration of exposure to durvalumab of about 7 months. So this is similar to what we've seen before. And again, the same story as we've seen in non-small cell lung cancer. The benefit of adding tremelimumab seems to be non-existent. Next. So this is the 3-year adverse events data. So the only thing I'm going to point on this study is that adding the CTLA which is the column in the middle, seems to increase the side effect risk. And as you can see in the bottom, the second line from the bottom, ACE leading to death of about 14 patients in the chemoimmunotherapy arm, 29 patients in the chemoimmunotherapy with the anti-CTLA antibody, and 16 in the chemotherapy arm. So again, a lot more side effects. All the side effects seems to be higher when you add an anti-CTLA antibody to this combination. Next. So this is the summary slide. Again, improvement in overall survival, very similar between the two anti-PD-L1 drugs. And adding an anti-CTLA antibody to the chemoimmunotherapy backbone. And no new safety concerns when you use just the chemoimmunotherapy with the anti-PD-L1 and avoid the anti-CTLA, consistent with prior findings. Next. Next. And then I'm going to show you a couple more studies. The first is the Atlantis study. Next. So the question here is, does lurbinectedin in combination with doxorubicin benefit patients with relapsed small cell lung cancer after one prior line of chemotherapy? As you all know, lurbinectedin is approved as a single agent in this setting in second line. Next. So the Atlantis study, the schema was that people all had to have received one prior line of treatment, ECOG PS of 0 to 2. So they did allow patients with performance status 2 for combination chemotherapy in the second line, and patients with a chemotherapy-free interval of less than 30 days. They were randomized to either topotecan given in the day 1 to 5 regimen.
Sujit, you're frozen again.
To doxorubicin plus lurbinectedin. Now, the one thing I would like to point out is that the dosage of lurbinectedin is lower than what is approved as a single agent. Now, when they went on to the maintenance, they were allowed to ramp up the dose of lurbinectedin to 3.2 milligrams per meter squared after completion of the adriamycin. Next. These are the study patients, so about 57% male, median age of about 63. Performance status of 2 was only a very small number of patients that you would expect. About 2 to 4% of the patients were PS2. Everybody else had good performance status. Median time of since diagnosis of about 9 months. Bulky disease of about 45%. Prior immunotherapy in this trial was low at 6% versus 5%, partly because it was not approved at the time the study was designed. Median time to progression to prior chemotherapy of about 7 months. Median chemotherapy-free interval of about 115 days. Patients who had a reasonable response to frontline treatment. Next. This is the efficacy analysis, and as you can see on the left, it's as negative as you can get. The lines practically superimposed on each other. Median overall survival by numbers is a little better. Hazard ratio is 0.6, so the p-value are not close to being statistically significant at 0.7. Look at the PFS, there seems to be a trend for an improvement in PFS. The p-value is 0.04, and the 6-month PFS in from 24% to 31%, and 1 year it was preserved at 4.4 versus 10.8%. Next. These are looking at the subsets. Again, nothing major here except that the response rate seems to be very similar between the two, but the duration of response is higher. Possibly due to the maintenance of lurbinectedin, which was allowed. The response rates in both the arms was about 30%, but the median duration of response was about 2 months better with the lurbinectedin arm of 5.7 versus 3.8 months. Next. Safety-wise, when you topotecan or CAV, significant evidence suppression. Remember, this regimen day 1 to 5, not a weekly dosing. And then the rest of the side effects are fairly similar to both the arms. Next. So essentially, it's a negative trial, did not provide overall survival benefit. And the question which still remains is, is this any better than single agent lurbinectedin by itself? Because remember, in the lurbinectedin trial, the doses were slightly higher. And overall survival, when you look overall response rate, when you look at single agent lurbinectedin is about 35%. median duration of 5.3. Sure, this combination is forward. So still, agent lurbinectedin is very choice in the second line. Next. We're going to talk quickly about the other two immunotherapy trials, Keynote 4 and Checkmate 4.1. Next. So as you all know, both those drugs have now withdrawn of their indication in small cell lung cancer. So both Keytruda and Opdivo have both withdrawn that, and most of us are not using in the clinic. This is a quick update on their data. It's hard to say why the PD-L1 drugs succeeded and the PD-1 drugs did not. I mean, we're learning more about this. Does this have anything to do with the lymphocyte response in small cell lung cancer? Quite clearly an area of ongoing research, but don't have any definitive answers. But as you can see in the Keynote trial, median PFS of 4.8 versus 4.3, and in the Checkmate 451, 1.7 versus 1.4. Median overall survival again, 10.8 versus 9.7 months in the Keynote trial. Some benefit there of maybe about a month. In the Checkmate, very similar overall response rates, some small improvements.